This is Dr. Barnes. Welcome to the renal course. This is the first of a series of online interactive lectures that I'm going to be providing for you in this course. Today's course will include 3 different sessions, mostly covering the water and sodium balance. I hope this sets a foundation for you to be able to grasp this material a little bit better and use this as an adjunct to the small group and large group activities and the workshops that we have prepared for you on water and sodium balance. So why don't we go ahead and get started so we can make sure that we get through this in a timely manner. So first we should start with some definitions. I believe most of you are probably familiar with the term osmolality, but I want to make sure that you understand its significance and how it relates to sodium and water balance. Osmolality measures the concentrations of solutes and water in the blood. The major substances that we find in the blood are found in an equation that we can use to calculate the serum osmolality. As you see here, we have a calculator of 2 times the sodium plus glucose over 18 plus BUN over 2.8. What I want to point out to you here is that we have a normal serum osmolality of 285. So, and the major component of this equation is sodium because it's 2 times the sodium rather than having a number in the denominator that makes it a little bit less significant or contributor to this equation. So this is why the sodium and water go hand in hand when we're evaluating patients' serum osmolality and determining how much water is in the blood. So if the number's lower than 285, we call that hypotonic or osmotic, and we'll discuss tonicity here in a second. If it's higher than 285, we call that hypertonic. And if it's the same, we basically call that isoosmotic. And we'll get into when and how we use this terminology in this equation as we go forward here. So what is tonicity? What's the difference between osmolality and tonicity? When we talk about tonicity, we're talking about intracellular values. Osmolality measures the concentration in the blood, the water concentration in the blood. Tonicity basically measures the water concentration inside of the cell. As you can see, the equations are fairly similar between these two, okay? And the only difference is that we don't have the blood urea nitrogen measurement in the tonicity equation, and that's because the urea goes in between intracellular and extracellular freely, and to actually get a good estimate intracellularly, it only contributes to a small amount inside of the cell. But I want you to be familiar that we'll use these terms interchangeably, meaning hypertonic or hyperosmotic, hypotonic or hypoosmotic, isotonic or isoosmotic. And we use them interchangeably because the equations are so similar and the numbers can be used interchangeably as we go forward. So when we're talking about these two, we're mostly talking about water in the blood or cells. And I want you to remember that. That's what we're talking about when we're talking about these two. Now, when we go on to discuss things like hypovolemia, hypovolemic, now we're talking about the volume of a substance inside of the body, mostly the volume of fluid inside of the body. So when someone's hypovolemic, they are low on fluid. And it mostly represents a particular portion of the body, which we'll go over later, which is the extracellular fluid volume. And if someone's hypovolemic, it's most likely that they have a low extracellular fluid volume. So they have a low extracellular fluid volume. Now, if someone's euvolemic, represented here, their extracellular fluid volume is normal. There's no change in their extracellular fluid volume. And then, of course, if someone is hypervolemic, they have a high extracellular fluid volume. What I want you to understand here is we are not talking about water volume. This is extracellular fluid volume. And we assess that by physical examination, and there is no particular lab test that we order to make sure that we can assess someone's volume status. And you'll get the hang of this as we go through some cases in small group and large group. But I want to make sure we get some of these definitions out before we go forward. All right. So now, how do we define hyponatremia? Hyponatremia is defined as a patient who has a sodium level less than 135. And that's a serum sodium level less than 135. So I want you to understand that what we do is we actually have to order that lab value to get that number. So you first get a value of 135, and then you establish at that point that the patient has a low sodium level, sodium concentration in their blood. Okay? So when we talk about hyponatremia, there's a couple of hormones that we really need to discuss before going forward. The main hormone I think you heard about back in your endocrine course is vasopressin, otherwise known as antidiuretic hormone, or ADH. Okay? And the importance of ADH is to make sure you understand when you say antidiuretic hormone, what's happening is in the kidney, you are now preventing the kidney from losing water. So that means you are reabsorbing more water back into the blood. So you increase free water in the serum when vasopressin is present within the kidney. So it's free water, not sodium in water like we're used to with other hormones, like the other hormone that you heard about in endocrine, which is aldosterone, which works at a similar location within the renal tubule. Here, you're increasing sodium plus water reabsorption inside of the blood. Okay? So you have to make sure you understand the differences, because if you're just reabsorbing free water, you can see how that might change the outcomes of the concentration of different substances within the blood. But if you reabsorb both sodium and water, what you might be creating at that point is more of an isotonic solution. And we'll go through that in more detail here in a few minutes. So let's look at this nephron, okay? Yes, it's my version of a nephron. So what I want you to recognize here is that this nephron has what we call an efferent arteriole, an afferent arteriole. Okay? This is your proximal convoluted tubule, and this is your descending loop of Henle, and this is your ascending loop of Henle. This would be your distal convoluted tubule. And this region here is where majority of the activity goes on as far as antidiuretic hormone. So ADH works here, which is your collecting duct. And it works on a specific type of cell called a principal cell, which you've been hearing about from Dr. Talbot during our physiology sessions, okay? And when ADH is present in this portion of the nephron, you start to reabsorb free water back into the blood. So this is your blood system here. And you start to reabsorb more free water back into the blood, okay? So I want you to understand that it's free water that's coming in when ADH is present, and that will affect concentrations of substances in the blood. And like we mentioned earlier, the sodium is a major contributor to osmolality in the blood. And so if you reabsorb more free water, what you will be doing is decreasing your sodium concentration. And we'll go through some calculations to help you recognize that. So, I think most of you recall the compartments of the body with the different fluid compartments of the body. But I want to make sure we do a good review here so that we lay a sound foundation as we go forward, because we're going to take some of this stuff for granted as we discuss these within the cases. So, what I want you to recall is a total body water for a normal adult is between 60 and 70% of their total body weight. Okay? So, each and every one of us is made up of majority water, and it is broken down into several different compartments, in which I've tried to outline here for you. Okay? So, first, I want you to observe the extracellular fluid compartment. Okay? And within that extracellular fluid compartment, you have the intravascular space, and you have the interstitial fluid space. Okay? These spaces are connected by way of capillaries. As you know, things can cross freely through the capillaries between your intravascular and interstitial fluid space. So they usually are grouped together and just termed both together, that they are the extracellular fluid space. Okay? So one and the same, you will know that having putting something into the extracellular fluid space, you expect that there would be a lot of similarities with where they go. So let's discuss that a little bit more, okay? So let's say, for instance, you add free water into your extracellular fluid space. What's going to happen is this free water will not only cross this way into the interstitial fluid space, if you put it into the intravenous, because that's the only way we can really add things directly through the intravenous. But water will cross freely over into your, what we call the intracellular fluid space. It crosses freely across. So eventually you're going to get an evening out, and almost immediately when you give free water, an evening out of this free water from the intravascular to the interstitial fluid to the intracellular fluid space. And the reason this is important will become evident to you here soon. Okay? Now, let's discuss if we actually give someone sodium in the form of, let's say you're giving them saline. And saline is sodium chloride solution as an IV fluid. Okay? So let's say you're giving them saline into this space. The difference here becomes that saline does cross freely between the intravascular space and the interstitial fluid space, but because this region has a membrane, because all cells have a membrane, it requires a transport of sort for saline to get across here. For sodium molecules to get across this cell membrane, you need a transport. So when we're trying to resuscitate someone and we want that fluid to go into the intravascular space to maintain blood pressure or make sure that we are rehydrating them acutely, what we do is we give normal saline, which is 0.09% sodium. And the reason we do that is because that is what we call isotonic fluid. And by giving isotonic fluids into the intravascular space, what you do is it stays here and doesn't cross the membrane because there's no gradient to pull it across this membrane. It's going to stay in the intravascular space because it is an isotonic fluid. Okay? That will become important as we go forward in understanding why some patients, when they retain sodium in water, it won't affect their body the same as if they just retain free water. Because as we pointed out, having free water go back and forth between these spaces will then eventually even out as we go across. Okay? So, now let's review a little bit. We have the intracellular fluid space, the extracellular fluid space that's composed of the intravascular space and the interstitial fluid space, and we have a membrane in between. Okay? Now, let's say we want to, for simplicity's sake, let's call this your y-axis, and this will be your x-axis. And the reason we're going to do that is because what I want you to recognize as we go forward is this y-axis will be represented by the sodium concentration, and this x-axis will be represented by volume. Okay? So, if we actually decide at some point to add certain substances in here, you might get changes in your sodium concentration or you might get changes in your volume. Okay? So more on that later. We're going to go on and give you an idea of how much fluid we have in each one of our spaces. Okay? So in our intravascular space, as you can see, in our intravascular space, you can see it's about 4 liters of fluid in that intravascular space. In our interstitial fluid space, we have about 10 liters of fluid. But far and above, we have 28 liters of fluid in our intracellular fluid space. Okay? And the reason that's important is because this makes up a good 2/3 of that total body water that we're discussing. And this makes up about 1/3 of that total body water that we are discussing. And of this, 1/4 of this 1/3 part makes up your intravascular fluid space, and then 3/4 of this extracellular fluid space is made up by your interstitial fluid space. Why are these numbers important? Because as you can see, when you add water into this area, as we discussed earlier, when you add water here, as we discussed earlier, we have to understand that where the majority of that water will be going. As you can see, this is about 2 times this space. So if you add water, 2 times of that water will be going into your intracellular fluid space. And you can see how that would affect your body if you're adding free water without anything else directly into your cells. And we'll discuss some of those effects as we go forward. So that's why it's important to recognize that the majority of this fluid goes into the intracellular fluid space, and since we have this membrane where water crosses freely, there is no barrier to that water getting into the intracellular space as we had when we were talking about the sodium concentration. So, again, we will review by saying that this region here, if we go up here, we are talking about the sodium concentration on the y-axis, and if we go along the x-axis, we're talking about the volume, and the reason that's important, as I've outlined here, is because as we start to make changes here to our fluid spaces, you have to recognize what would happen, okay? For example, let's go back to our example of adding water into your extracellular fluid space. What's going to happen? 2 times of that water will go into this intracellular fluid space. And what's going to happen as you add water to this area is you get a small increase in volume, but you get a significant decrease in the sodium concentration along that y-axis. And the reason being is because the water is going to distribute freely through here. And so you don't add much volume. And the volume that you do add, probably majority of it would go to this side, since 2 times of that is going into your intracellular fluid space. Okay? So that being said, what we see is a decrease in the sodium if you add free water without getting rid of it through your kidneys. If there's a defect, you will decrease the amount of sodium in the blood because you're not adding saline, you're adding water. So now, on this same image, let's discuss what happens if we add saline. Now I'll just call that NS, okay, into the extracellular space. What you'd be doing then, let's do our Y and x-axis again. What you'd be doing then, since normal saline is an isotonic fluid, you'd just be adding to the volume. Because as we pointed out, it won't go across here. Because the majority of that stays in the extracellular fluid space because it is the same concentration of sodium that's already inside of the blood. So that will just add volume rather than actually going across and causing a decrease in your sodium level. So your sodium concentration stays the same because normal saline has the same amount of sodium concentration that's already in the blood. So you won't get a hyponatremia or a lower serum sodium by adding saline. Okay? But you do add volume. So that's why when we're trying to resuscitate a patient who has low blood pressure and they become hypotensive, we give them an isotonic substance. And when we talk about isotonic, isoosmotic in the form of saline, because we know most of that is going to stay in the extracellular fluid space and in increasing the intravascular and interstitial fluid volume. Okay? That's also why when we add water, free water, to this area again, we talked about only having a minor increase in the amount of volume. You get double the amount of water crossing freely across this membrane here. And you might get a little extra, more than you do over here on the extracellular fluid space. You might get a little extra volume going this way. But majority is you're decreasing the concentration of the sodium when you add free water. But the key here is you're not adding much volume to the extracellular fluid space, so when you hold on to free water or add free water into this space, there is no edema. These patients do not get edema. So patients who are retaining just free water in the form of ADH, they don't get edema because there's very little increase in volume in this interstitial fluid space. So they don't get leg swelling, they don't get edema around their lungs. There's very little of that because majority of that water is going to this large 2 times space that we talked about, and it will prevent them from getting edema. Now, let's talk the reverse of that. If we add normal saline, those patients are increasing their volume and then increasing their extracellular fluid space by a lot if we give enough saline. And these patients will get edema. So that's why patients who actually have an increase in aldosterone, which you guys learned in endocrine, will have edema. Because what you're doing is you're reabsorbing salt and water, and they will get edema. But in contrast, in patients who have increased ADH, meaning holding on to more free water, most of that free water is going here and not into your interstitial fluid or intravascular space. So these patients don't get any edema. Okay? So when you have an increase in ADH, and that's free water that's being reabsorbed, not sodium in water, because remember, the sodium didn't cross this membrane. The water can freely cross. It spreads it out more. You don't increase much of the volume. So these patients don't get edema. Okay? And this will help with your discussion as you go forward in establishing how your patients are going to respond to therapy and how to diagnose them. Okay? So, let's move on. What I want you to think about when we talk about ADH let me fix this here. What I want you to think about when we talk about ADH, is likened to water. Okay? And when you think about aldosterone, we're talking about sodium in water. So in patients who have hyponatremia, ADH is the driving force, so we can probably easily establish that patients with hyponatremia have a water problem, not a sodium problem. Since ADH is the driving force, so when you think ADH, think of a water problem. When you think hyponatremia, even though by definition we're calling it low sodium, it is a water problem, okay? Patients with hyperaldosteronism, they don't get hyponatremic because they're reabsorbing sodium and water, okay? And then recall that patients with just an increase in water, there's no edema. But since they're reabsorbing sodium and water, these patients here get edema. Okay? Sorry to drive that home, but it's a big question that I get every year that I wanted to get out of the way to make sure that you guys had a good understanding about. So, now let's get to the meat of hyponatremia, okay? So when we're talking hyponatremia, remember, what did we say? We said that by definition, hyponatremia is a low sodium concentration in the blood, and we defined it as a sodium less than 135. Okay? So, what do we do once we find that sodium of less than 135? The next step for each and every time you find a low sodium is you need to find out what the patient's serum osmolality is. Remember, you're asking yourself the question when you talk about osmolality is what is the water concentration in comparison to the solutes in the blood? So you say, what is the water concentration? Because remember, I told you hyponatremia is majorly a water problem, less of a sodium problem. So you have to send a lab off for a serum osmolality. I did teach you an equation that you can use while you're waiting for the lab to try and get an estimate of what that serum osmolality will be. And that equation I listed here, so you can actually calculate it by going 2 times the sodium plus the glucose over 18 plus the BUN over 2.8. So while you're waiting for the measured serum osmolality, you can easily get a good estimate of what the osmolality would be in each of these patients, okay? So, but the first step after you identify low sodium from a lab value that you've ordered would be to get a serum osmolality. And after you get that, then you have to say, remember we're using these terms interchangeably. When we say isotonic, that's similar to saying isoosmotic. You have to determine, and remember to back up one step, remember we said the normal serum osmolality was 285 milliosms per kilogram. Okay? So, if it's 285, then those patients are called isotonic. Okay? We usually say if it's greater than 300, they're hypotonic. And somewhere around 270 or less than 270, we'll say they're hypotonic. Okay? So, now you've established where you can put this patient into these different groups. Okay? And from there, it helps with your differential diagnosis, and then that will lead to help with your management of these patients. Okay? So, next, if they are isotonic, there are a few causes. This one we actually have renamed to be, sorry about that, pseudo hyponatremia. And we'll get into the details of that as we go into our next section. I just wanted to give you a good introduction. And the hypertonic is when you actually have an increased tonicity or increased osmolality in the blood. There are a few causes that like added substances like mannitol, which will add to the tonicity or the osmolality in the blood. There's glucose in patients who have hyperglycemia. There are other substances like toluene, which is a paint thinner, that might add to this. And then ethylene glycol is another cause, which is basically antifreeze. Okay? But far and above, because it is a water problem, these patients fit into the hypotonic. Somewhere around 90% are hypotonic. Okay? So if 90% of these are hypotonic, this is where we're going to focus most of our activities. But right now we're going to go ahead and move forward and take a break. And on the breaks, what I want you to do is go to this next set of questions that will hopefully help you solidify some of the information that we just went over in this last section. And then what we'll do is come back at the outset of our next session just to do a brief review and go forward. But make sure you answer the questions before going forward to make sure you have a good foundation before we build on this information as we go.